I'd like to introduce Dr. Fiona Runacres from Monash Health, who's going to tell us about managing malignant effusions using rockets on HITH and managing pain in cancer patients. So Fiona Runacres is a palliative care specialist working at Monash Health and at Calvary Health Care Bethlehem in Melbourne. Fiona works across inpatient, community and outpatient settings, has adjunct appointments with Monash University and the University of Notre Dame. Fiona's clinical work in neuropalliative care and renal supportive care services has helped develop her interest in palliative care provision for patients with life-limiting non-malignant disease. Fiona's worked with the Monash HITH service since 2019, and that's been highly rewarding to be able to explore new ways to support palliative care patients to receive the care they need at home. Thanks, Fiona.
Thanks very much for the opportunity to take, I guess, a different slant on hospital in the home work in a palliative care intervention or setting for palliative care patients. I'll just have to move my images so I can find the slides. Today I'll just provide a bit of an overview or context behind Monash Health and the palliative care services and the current structure in Victoria for palliative care supports for patients in the community setting. Also discuss some of our HITH palliative care procedures that we have focus mainly on the indwelling pleural and peritoneal catheter population because they're our largest HITH palliative care patient cohort, as well as introduce, I guess, the role of HITH for cancer pain management and our latest expansion into supporting palliative care patients to receive continuous subcutaneous infusions using a Shaw Fuser device. I've got a few clinical case vignettes throughout just to try to keep it relatable to this audience. So Monash Health is a large tertiary public health service in Melbourne. We have 5 public hospitals, 1 private hospital and a number of community services, as well as a large hospital in the home service that is based through 4 different campuses, which covers a large catchment area. We have quite a sizable palliative care and supportive care department. We have a 16-bed inpatient unit at Clayton McCulloch House that has about 450 to 500 patients that they support each year. We have some inpatient beds at Casey Hospital, and we have a bidisciplinary consultation service that supports all our public and private hospitals, and they care for approximately 1,500 to 2,000 patients per year. And just this year, we expanded our consultation service to create a rapid arm, which is geared at supporting Monash Health patients in the community setting, of which HITH has become a significant referral source for inpatients, but technically residing in the community setting. We also have a number of palliative care clinics. In Victoria, every postcode falls under a catchment area of a community palliative care service, which in the vast majority are state government funded. In metropolitan Melbourne, there's 8 different community palliative care services according to which council area you live in. And they really differ in terms of their structuring and resourcing. Some are predominantly specialist nurse services that work closely with GPs to provide palliative care services. Other community services are large training services for palliative medicine specialists, so have palliative medicine consultants and registrars. They also differ in terms of their 24-hour support. Some will offer home visits, whereas others offer phone support. And in regional Victoria too, there's considerable difference in the range and degree of specialists that are available. And I've been fortunate at Monash that both the HITH service and the palliative care service have had a mutual interest in each other and how they can help support palliative care patients receive care in the community or their home setting. HITH at Monash first started supporting patients with rocket drains back in 2016, and they've really just continued to build relationships between the 2 departments throughout this time. And into mid-2019, HITH employed a palliative care specialist role, 1 EFT, which has really enabled us to have significant traction in developing our service provision through HITH. And the rapid aspect, so bolstering the palliative care resourcing in the community space has also really helped with what we've been able to achieve. So just to give an overview of the palliative care HITH procedures that we currently have in place at Monash Health. So we started off with our pleural rocket drains for malignant pleural effusion patients and indwelling peritoneal catheters for patients with malignant ascites. Identified a need for cancer pain support, and a pain control procedure was developed in 2017. And now this year that's expanded to be inclusive of haematology oncology patients as well, in response to need. And then this year we've seen HITH expand again to be able to deliver continuous subcutaneous infusions for palliative care patients. So first, just to start with our rocket service. So indwelling catheters, the common brands being PleurX or rocket drains, are really designed as a device to drain a recurrent effusion to prevent the need for repeat hospitalisations or intermittent taps. And when I first started working in HITH, the expectation was that this was most commonly a population with very advanced malignant disease, often at the end of any active anti-cancer treatments, and most likely to be in the last weeks to 3 months of life. And the longer we've supported this population, we've realised how diverse and heterogeneous they really are. While many do have advanced disease, some people are having rockets inserted even pre-diagnosis of their malignancy, and perhaps before they've embarked on any anti-cancer therapy. There's many specialty units at the hospital that are becoming more familiar with the use of a rocket drain as a device or as an intervention. And there's a number of points of insertion, either in interventional radiology at a number of our public hospitals, or by cardiothoracics in surgery. And HITH are also supporting a growing non-malignant cohort, so patients with chronic liver disease and refractory ascites, and patients with end-stage heart failure. And these non-malignant patients are referred to the palliative care HITH support on a case-by-case needs base. This just illustrates how the rocket drain HITH patient numbers for malignant effusions has really increased every couple of years. So we haven't had the full patient cohort for 2020 yet, and already it's more than double the preceding 2 years. And while the majority of the HITH palliative care patients with rocket drains do have malignant disease, so malignant ascites being the most common indication, we do have a small cohort of patients with non-malignant ascites, and that's similar in our patients with refractory recurrent pleural effusions. We have a few patients with non-malignant refractory effusions.
Tell us the cost of rocket and PleurX drains.
Yeah, that's a good question. The cost is often in the ongoing maintenance. So a vacuum sort of bottle is about $80 from my understanding, and a sterile dressing pack with all the connections is about $150. So previously that's been a real barrier for community palliative care services to be able to support palliative care patients to have a rocket drain if the patient themselves hasn't been able to fund that recurring need for bottles for exchanges and the sterile dressings. And that's often outside the scope of community palliative care services to fund. Some patients that we look after have twice daily drains. So if they're paying $80 a bottle and $100 and something a dressing pack, there's a quite extensive just daily cost involved with that.
Whereas obviously under the HITH acute funding, that's obviously much more palatable. It
is, yeah. I thought I'd share just one example or two examples of a typical rocket drain patient. We met a relatively young 47-year-old lady who presented to hospital just in October last year, and that she had bilateral pleural effusions, and that was her presenting symptom for metastatic triple positive breast cancer. She had bilateral rocket drains inserted during her hospital stay, but she had quite such extensive disease at time of presentation that really she wasn't well enough to return home. She had high level care needs and was actually discharged from hospital on endocrine therapy into a residential aged care facility. So that was after a 3-month sort of hospital stay and workup. So hospital in the home was involved at that point of hospital discharge, really had to do significant work to help a young lady settle into a residential aged care setting with a relatively recent cancer diagnosis and uncertain prognosis. Her left rocket ceased having any appreciable output after about a couple of months being home or being in the residential facility under HITH. That was causing her pain at that site. So HITH arranged to electively remove that by cardiothoracics. However, her right rocket site persistently had drainage about 300 to 800 mils. So sometimes she was having daily drains with good symptom relief. Other times when the volumes were lower, she was having alternate daily drains. And that lasted for 9 months. And she only had one elective hospital stay. Apart from the rocket removal procedure, she had one elective hospital stay to treat hypercalcemia. And HITH had a plan to be able to give her treatment for that ongoingly in the residential setting if needed. She was quite complex in terms of her analgesic regimes, anxiety management, dyspnea management. So HITH and our rapid palliative care aspect worked really well with her community palliative care service provider and her GP to really help everybody be confident with what their role was in her care management and to successfully keep her comfortable in the facility. And she died a year after diagnosis. So that right rocket was in for a year without any complication. Another patient who's been referred to HITH for rocket management is a 72-year-old man with advanced heart failure, secondary cirrhosis and stage 4 kidney disease. And he was referred to the complex care community aspect at Monash Health and subsequently a palliative care outpatient clinic because he'd had multiple recurrent hospitalisations throughout 2019. His baseline, he's hypotensive, he's on maximal diuretic therapy is tolerated, and then was developing a refractory ascites, which was initially managed with recurrent acidic taps. He had essentially monthly or 3 weekly outpatient taps, totaling 8 different taps between December 2019 to June this year. And they really were suboptimally managing his symptoms. The ascites would accumulate maybe after 2 weeks to cause anorexia, nausea, constipation, pain, shortness of breath when he was on exertion or lying flat. And then he really had to sort of endure another couple of weeks to last a month before having another elective outpatient tap. It was also quite logistically complicated because to make that tolerable for him, we had to ensure that he withheld his antiplatelet medications a day before, he had to withhold his diuretic medications a day before, or his hypotension was really problematic in an interventional radiology space. And then he'd have anywhere between 2 and 4 litres drain in that outpatient setting. So after a bit of discussion, he agreed to try a rocket drain, which was inserted, and then a referral to HITH. And that's really allowed him to have weekly or twice weekly drainage according to his symptoms, which has significantly improved his quality of life, and he's really appreciating care in his home setting. So the benefits of having an indwelling system for the cancer or the frail chronic illness population, obviously it reduces hospitalisations and hospital elective procedures. Patients appreciate the care in the home setting, and they do tell us that their symptom burden is much better managed. The drainages are more tailored around their needs, not when the hospital can fit them in for an outpatient tap. They're not having such significant fluid shifts, so the drainage is better tolerated. And even when people are approaching the end of life and are really more functionally impaired, maybe not well enough to be coming to radiology departments, they can still access a drain for symptom relief. They've also told us that they've found the medical care that they get, they have at least a minimum weekly medical contact under HITH. And we've also been able to arrange investigations really timely, given that they're officially in an inpatient population. And we have been having early introduction to palliative care for a number of these patients, and then tapping them into community services for that earlier palliative care support than they would have necessarily received otherwise. So what's been the palliative care role in HITH? In this instance, well, often, even despite patients having very extensive cancer diagnoses, often they've been keen, they're very treatment focused, they might be on their third, fourth, fifth line, or awaiting clinical trials. So maybe the home teams haven't felt it was timely to introduce palliative care, or patients have been a bit worried about the notion of a community palliative care service. But being introduced via hospital in the home as an additional support is comparatively less threatening. We've really done work in coordinating care when people are in the community setting. There is multiple potential players, so GPs, community palliative care services. Patients often do want to stay in contact with those other providers. Another benefit has been the ability to coordinate concurrent specialist reviews. So when people have come into a HITH clinic, we've been able to have a WebEx consultation with ourselves from palliative care, and also invite their haematologist or their oncologist to that. And that's been, I think, appreciated on both sides, because some of the oncology, haematology clinics haven't necessarily been using virtual video conferencing. And our role, or I see the palliative care role, is really having a greater emphasis on determining goals of care, stepping into that space of shared decision-making with patients and families about, as their health deteriorates, where would they like to be? Is their preference to remain home, if at all possible? If they're feeling more unwell, would their preference to be electively admitted into a palliative care unit? And are we actually draining for comfort and not focused on vital sign parameters? Or is this somebody who is undergoing active anti-cancer treatment, and then we're very much responsive to vital signs? And we're also supporting the HITH staff who are caring for patients sometimes at the end of life. So just to change tact and discuss briefly our oncology pain management procedure. HITH can be referred patients, cancer patients who wish to be discharged home earlier, or they might already be outpatients and attend our oncopain clinic and not wish to have inpatient care, and HITH provides an alternative pain management option for those patients. Under HITH, they have twice daily nursing visits, including pain and other symptom assessment. The HITH nurses liaise with a palliative medicine specialist each day. And some of the indications may be converting parenteral opioids to an oral regime, or an opioid rotation, including methadone titration, which typically would occur in an inpatient palliative care setting or a hospital environment. So HITH have really upskilled in their pain assessment skills, and they've reported that they find those clinical monitoring patient visits enjoyable and rewarding. And this year we've broadened that to the haematology oncology patients. So an example would be an 88-year-old lady who was diagnosed with locally advanced parotid SCC. Her GP had been managing her pain in the community, and then the ENT team referred to the oncopain clinic. At that first clinic, she was identified to have extremely poor pain control. She was having opioid toxicities secondary to the Norspan patch. Was offered an inpatient admission to consider an opioid rotation and flatly refused, very determined to return home to a home alone environment. So she had a 9-day admission under HITH with BD nursing visits. The palliative medicine team reduced her Norspan back to her lowest dose that was shown to be tolerated, and commenced some oral methadone. During the HITH admission, she did have nausea and reduced oral intake, and then unstable beta cells and some mild opioid toxicity. So the Norspan patch was removed completely. And then when she was just on methadone 5 milligrams BD alone, her symptoms significantly stabilised and improved. But I think without that HITH support, she would have been in ED quite unwell. And she just has ongoing oncopain outpatient follow-up now. An example of haematology patients that can benefit from this procedure too is potentially multiple myeloma patients for additional supervision around interventions for their pain management, such as vertebroplasty and adjusting the analgesics post-procedure. Some patients have declined a community palliative care service involvement, maybe because they are on active treatment. And sometimes we've had barriers with patients requesting to have some community palliative care support, but if their prognosis is deemed greater than 12 months for some community services, that's been a barrier to accepting those patients. And then we've also had a few haematology patients that HITH have supported for end-of-life care. And they're often patients that have deteriorated suddenly or unexpectedly, and they haven't yet been linked into community palliative care services. Sometimes if they receive news in hospital, especially in the COVID environment, that ongoing active hospital treatments aren't being helpful, quite quickly they've wanted to be home in the community setting where there's no visitor restrictions. And HITH has provided a bit of a bridging, HITH palliative care bridging support until community palliative care can be referred, which leads us a bit into HITH end-of-life care. Yeah. Just briefly, we recognise that the majority of Australians say they wish to die at home, but still recently our data shows that the majority of people are dying in hospital, even though they do have more chronic illness and potentially death is more predictable. So the HITH Shawfuser procedure to deliver continuous subcutaneous infusions of palliative care medicine is an exciting development really this year to hopefully enable people who are presenting to emergency diagnosed as dying to be able to return home with palliative care infusions running until a community palliative care service can be referred and engaged. And that is it. So thank you. Thanks for your patience and apologies for those technical delays as well.
Thanks, Fiona.